You know, for any clinician, being able to accurately classify a spinal cord injury is absolutely fundamental. It's not just some academic exercise. It's what guides our treatment, helps predict a patient's future, and, really importantly, make sure we're all speaking the same clinical language. So today, we're going to break down the global standard for doing exactly that. Okay, so here's our game plan. First up, we'll cover the essential anatomy. You got to know the hardware. Then we'll walk through the neurological exam, step by step. After that, we'll see how to take those findings to pinpoint the exact injury level, grade how severe it is using the ASIA scale, and finally, we'll look at some of the classic spinal cord syndromes you'll definitely see in the clinic. All right, first things first. Before we can even get to the how of classifying an injury, we've got to understand the why. We need to know the structures at play and the cascade of events that kicks off when that delicate cord gets damaged. This is the foundation for everything else we're about to cover. Think of the bony vertebral column as this incredible suit of armor, and inside is the spinal cord. It's best to think of the cord as the body's master data highway. It's constantly relaying sensory information up to the brain and sending motor commands back down. It's a two-way street. Now, this is an absolutely critical concept. There are two phases to the injury. First, you have the primary injury. That's the initial mechanical hit, the fracture, the compression. But what comes next is often just as devastating. It's called the secondary injury, this vicious cascade of inflammation, lack of blood flow, and cell death. And honestly, so much of what we do in the ER is aimed at stopping this secondary hit from making things even worse. So if you look at this cross-section of the cord, you can see how different functions are neatly organized into specific pathways, or tracks. You've got the corticospinal tracts for motor function, the spinothalamic for pain and temperature, and the dorsal columns for things like proprioception. That's your brain's sense of where your limbs are in space. Understanding this functional map is exactly how we can figure out where a lesion is just by doing a good clinical exam. All right, let's get to the main event, the practical hands-on assessment. We're talking about the International Standards for Neurological Classification of Spinal Cord Injury, or as everyone calls it, the ISNCSCI exam. This is the global gold standard. And this is it, the official worksheet from the American Spinal Injury Association, or ASIA. I know, it looks a little intense, right? But trust me, it's an incredibly logical tool. We're going to walk through how to fill this out piece by piece so it makes perfect sense. The whole thing really boils down to 3 core steps. It's very systematic. We start by testing sensation, then we move on to motor strength, and finally, we do a really crucial check of the lowest part of the spinal cord. First up, dermatomes. So what's a dermatome? Well, it's just a specific patch of skin that gets its sensation from a single spinal nerve root. We test 28 of these key spots on each side of the body, using both light touch and a pinprick. We then grade the sensation, 0 for absent, 1 for altered, and 2 for totally normal. This lets us draw a very clear line on the body where normal sensation stops. All right, so if a dermatome is for sensation, the motor equivalent is a myotome. It's the same idea. A myotome is a group of muscles that's powered by a single spinal nerve root. And just like with the sensory exam, we're going to systematically test 10 key muscle groups on each side to create a precise map of motor function all the way down the cord. And this table gives you a great snapshot of some of those key myotomes we test. For instance, you want to check C5, you're going to test the elbow flexors, the biceps. For C7, it's the opposite, the elbow extensors, your triceps. We just keep going down the body. L2 is hip flexion, S1 is pushing down with your foot or plantar flexion. And we grade each one's strength on that standard 0 to 5 scale. Okay, we've arrived at what is, without a doubt, the single most important question in the entire exam. This is the one that separates a complete injury from an incomplete one. We have to assess for what's called sacral sparing. This means checking for any sensation down in the S4, S5 dermatome, and critically asking the patient to perform a voluntary anal contraction. If there's any function there at all, it tells us that communication highway isn't totally severed, and that has huge implications for potential recovery. All right, so we've done the legwork, we've got our sensory data, we've got our motor data. Now what? Well, now we put it all together to define the single most important descriptor of the injury, the neurological level of injury, or NLI. So how do we actually figure out this NLI? It's a pretty straightforward process. The NLI is simply the lowest, most caudal segment of the spinal cord, where function is still completely normal. We figure out the sensory level and the motor level separately. Then the overall NLI is just the highest or most rostral of those two levels. It gives us one single clear-cut level for the injury. Okay, so we've got our NLI. We know the level of the injury. The next question is, how severe is it? And for that, we turn to the Asia Impairment Scale, what everyone just calls the AIS grade. The best way to think about this scale is like a decision tree. And it all starts with that huge question we just talked about, sacral sparing. If the answer is no, no sacral sparing, it's an AIS-A, a complete injury. If the answer is yes, then it's incomplete. From there, we just have to figure out what kind of incomplete. Is there only sensory function below the injury level? That's an AIS-B. Is there motor function too? Then it's either a C or a D. And we figure that out based on how strong those muscles are. So here's a quick look at the grades altogether. You've got AIS-A, that's your complete injury, no function preserved down in the sacral segments. Then you have B, C, and D, which are all incomplete injuries. B is when you have sensation but no real motor function below the level. C and D are both motor incomplete, and the difference is just how much functional strength is preserved. And finally, AIS-E means the patient has returned to normal neurological function. All right, for our last section, let's bring all this back to the clinic. Let's connect the dots between this classification system and the real-world clinical patterns, or syndromes, that you are definitely going to see. For instance, let's talk about central cord syndrome. This is super common, especially in older patients with hyperextension injuries. The classic sign is having much more weakness in the arms than in the legs. Why? Because the arm nerve fibers run more centrally in the cord. Now contrast that with anterior cord syndrome. This is usually from a blockage of the anterior spinal artery. It wipes out motor function, pain, and temperature. But, and this is the key, it spares the dorsal columns. So the patient can't move, but they can still feel vibration and proprioception. And then there's the classic Brown-Séquard syndrome. This one is fascinating neurologically. It's caused by a hemisection. Basically, one half of the cord is damaged. Because the different nerve tracts cross over at different levels in the spinal cord and brainstem, you get this really distinct pattern. On the same side as the injury, the patient loses motor function and proprioception. But on the opposite side, they lose pain and temperature sensation. It's a true neurological puzzle. So to wrap all this up, what are the big takeaways? Remember, the ISN-CSCI exam isn't just a checklist. It's a powerful, systematic process. By methodically checking every dermatome and myotome, you can define the neurological level of injury. You can determine if an injury is complete or incomplete just by checking for sacral sparing. And you can assign an AIS grade to communicate severity. It's the universal language we all use, and it's absolutely fundamental for prognosis and clear communication. You know, this physical exam is our current gold standard, and it's an incredibly powerful tool based on clinical observation. But it does leave you with a final thought, right? As our technology gets more and more advanced, things like sophisticated MRI techniques or blood biomarkers, how will we start to integrate those into this classification to give us an even deeper, more predictive understanding of these devastating injuries?